Good morning. My name is Liza Kunz. I am the Systems Director for Endocrinology and Reproductive Health at Core Lab at Abbott. It's my pleasure to introduce Dr. Mrinalini Kulkarni-Date. Dr. Kulkarni-Date is an Associate Professor and Chief of Endocrinology in the Department of Internal Medicine at Dell Medical School at the University of Texas. She serves as the chair of the AMA Chronic Disease Prevention and Management Interest Group. Her interests also include mentoring women in medicine and gender equity in medicine. She is an expert in complex care in the underserved, particularly transitions of care, remote patient monitoring, and telemedicine. She has had numerous leadership positions and presented at national meetings in these areas. It is my absolute pleasure to welcome my dear friend, Dr. Kulkarni-Date, to Abbott and the ADLM Med Talk stage. Dr. Date.
Thank you. That was a very kind introduction. I have to say that support for this program is provided by Abbott. The views and opinions expressed are those of me. I will also say that most of my guidelines are based on national or international guidelines, not any of the guidelines I have magically created myself. And then anything that we say in this presentation is not intended to represent or guarantee that any lab will achieve the same or similar results. Okay, so let's just first review the pathogenesis of diabetes. So we hear most commonly about type 1 and type 2 diabetes, and most of the work has lots of work in both, but we hear more about type 2 diabetes, that it is more common. So what happens in type 2 diabetes? We know type 1 diabetes. We know type 1 diabetes is an autoimmune disorder. We have an attack on the pancreas with various immune cells, and that causes beta cell destruction. So what happens to insulin? We have a loss of insulin production. So in type 1 diabetes, we have an absolute insulin deficiency, so not enough insulin, and therefore we get hyperglycemia. Type 2 diabetes is a bit more multifaceted in that type 2 diabetes is a part of metabolic syndrome. There is inflammatory cytokines, so lots of inflammation. We have amyloid accumulation. We have hyperlipidemia, so many things going on there from a metabolic syndrome perspective. And we have a deficit, this defect on the insulin receptor at the cellular level. So while insulin is being produced by the pancreas, we're not getting adequate uptake into the peripheral cells. So we're actually early on in diabetes, insulin levels are higher or prediabetes, but over time we do have loss of beta cell function because the insulin just reaches a glass ceiling, if you will, and that pancreas can't secrete anymore. So that really leads to hyperglycemia. Well, let's talk a little bit about type 2 diabetes in the United States. So we know that 38.4 million people in the United States have diabetes. That's 11.6% of the population. This data is from 2020, so probably more now, as we know the incidence of diabetes type 2 diabetes is increasing. So we have 29.7 million people that we know have a diagnosis. But here's what's interesting and a little scary, that we still have 8.7 million people, or almost 23% of adults in our population in the United States that are undiagnosed. And that's undiagnosed with type 2 diabetes. That doesn't even touch on the people that have prediabetes. So it's a really large number. So if you think about the state of management of type 2 diabetes in the United States, despite the amazing progress in technology, the digital technology that we're using to monitor blood sugars, the pharmacology advances that have been made in diabetes, we're not doing that great. So just in June, the FDA Commissioner, Robert Califf, gave a talk and said, we are failing right now in type 2 diabetes. And I'll talk on the next slide a little bit about what the factors are that are contributing to this. The other thing we know in terms of prediabetes is that the National Diabetes Prevention Program is vastly underutilized. It is approved. Medicare pays for it, but we're just not getting people who have prediabetes to this program. So what's going on? Part of the problem is we have a lack of access to care. We still have lots of people in our country who don't have access to healthcare, don't have access to healthcare insurance. We're not adequately screening for prediabetes and diabetes. We're not catching people as they come into the emergency room or other places of healthcare where we might be able to say, okay, we've made a diagnosis of diabetes. We also have inadequate counseling, education, and treatment pathways for diabetes. There's a lack of population health-oriented programming within communities. There's not enough multidisciplinary team care due to health system cost. You always hear about how expensive diabetes is, and it's expensive for multiple reasons, but diabetes care, good diabetes care, really requires a multidisciplinary team. And that can put a burden on the healthcare system in terms of cost. So not enough access and not enough clinician time. I don't know how many of you are clinicians here in the audience, but my primary care colleagues, my internal medicine colleagues, family medicine colleagues, they all tell me about, well, I have 10 or 15 minutes with my patient in the outpatient setting, which isn't enough time. And we may not hit the screening that we need to do because we're working on more acute issues. Well, what are the criteria for screening for diabetes or prediabetes in asymptomatic adults? Anybody, so I'm going to go over these criteria. So adults who are overweight or have obesity, they have a BMI of greater than 25. For Asians, the cutoff is actually lower. It's a BMI of 23. So more stress. But anybody who meets that criteria, who has a first-degree relative with diabetes, is a high-risk race or ethnicity. Those high-risk ethnicities include African Americans, Latino, Asian Americans, and Pacific Islanders. Anyone with the history of coronary vascular disease, anybody with hypertension, hyperlipidemia, women with polycystic ovarian syndrome, because at the end of the day, women with polycystic ovarian syndrome have metabolic syndrome and are higher risk for prediabetes and diabetes. Physical activity, any conditions associated with insulin resistance. So those could be patients on high-risk medications, people with prediabetes, women with gestational diabetes are at a very high risk for developing diabetes later on, up to 50%, as shown in some studies. We're missing those individuals. Here's something that's interesting. If you don't meet those criteria, for everybody else, we need to be testing people starting at the age of 35. Now, I will tell you, as somebody who's been doing this for 20 years, this guideline kind of got put in pretty recently. And if you think about it, begin testing at 35. That's a very large swath of people that we are not testing. And then individuals with HIV, exposure to high-risk medications like glucocorticoids, some of the second-generation antipsychotics increase insulin resistance and can cause hyperglycemia. We need to be mindful about screening those individuals. So what are we testing? What are the tests that we're going to use? Fasting plasma glucose, random plasma glucose in the right setting, hemoglobin A1C, or a 2-hour plasma glucose after an oral glucose tolerance test. Now, I have to say, my least favorite in this list is fasted plasma glucose, and we'll talk about that later in the presentation, only because fasting plasma glucose, it's kind of the last glucose that becomes abnormal. It stays normal for a long time. You're going to see a change in a 2-hour plasma glucose before you see a change in fasting glucose. So here are the criteria. These are the American Diabetes Association criteria for prediabetes. So if you have a fasting plasma glucose between 100 and 125 milligrams per deciliter, you have impaired fasting glucose. Let me make a little caveat, and that is the World Health Organization classifies prediabetes as 100 to 110. So we vary a little bit globally. A 2-hour plasma glucose of 140 or 199 meets the criteria for impaired glucose tolerance. That's really the first time, if you're going to do all of these tests, the first time you're going to see glucose become abnormal is after the 2-hour glucose tolerance test. Why? because that's when the pancreas is the most stressed, right? That's when the pancreas is the most challenged to secrete insulin to maintain normal glycemia. Or if you have a hemoglobin A1C between 5.7 and 6.4. I will say in the United States, we're probably doing a lot more hemoglobin A1C testing because it's easy to do. You can lump it up with other tests. You even have point of care testing. Harder to catch patients who might be fasting, and 2-hour glucose tolerances take time. Many times you have to schedule it in the lab. So we probably do that less overall. Okay, well, why is it so important? So I'm a teacher. I have lots of medical trainees in my clinic. And I always tell my residents, I tell them, you're seeing more prediabetes than I am in my endocrinology clinic, and you have a golden opportunity to make a big impact on patients' outcomes. Because we know that if we implement lifestyle interventions in our patients with prediabetes or impaired glucose tolerance or those high-risk individuals, we can really delay their onset of type 2 diabetes. And this, I'm just showing this slide from the Diabetes Prevention Program. So many of you may have heard of this study. Diabetes Prevention Program was a study that took participants randomized to an intensive lifestyle intervention group. In that group, those individuals had, they did 150 minutes of exercise a week. That's 30 minutes over 5 days, just to break it up for you. It's not that bad. They were given frequent dietary counseling on a low-fat, low-calorie diet. There was not really this concept of low-carb diet in the study. And they were encouraged to lose enough weight. 7% of their body weight was the goal. So 7% body weight loss was the goal for these patients. And look what happened. In 3 years, the intensive lifestyle group decreased the incidence of diabetes compared to placebo by 58%. That is huge. It is so significant. That's better than some of the drug trials we're doing, right? It was a huge landmark study for us. I was in training at the time, and I was at one of the centers that was doing this study. We thought we were telling people the right thing, that they needed to be active, they needed to watch their diet, they needed to be physically active, but this really validated that for us. So it was a really big, important study. The second treatment group was patients that were put on metformin, 850 milligrams twice a day. They also reduced their incidence of diabetes by 31%. So drug actually did not as great as lifestyle. Another huge point for us to take home. The next thing I want to emphasize is, even after the study was over, the patients in the lifestyle group continued to confer benefit. Even up to 15 years, they are still having a delayed onset of diabetes compared to placebo. So there's something lasting about what they did during that study, which is significant. Same thing with the metformin group. If they continued on metformin, they also delayed their diagnosis of diabetes. So this is just looking at other smaller studies that also found that intensive lifestyle modification decreased the incidence of diabetes. And I want to just point out the number needed to treat, right? So in the DPP, you had to treat 21 people to get an effect. That's pretty good. And the program is pretty cost effective. So landmark study, really important, and why I always talk to my residents about we really need to be screening and finding these individuals because we can make a tremendous impact on their outcomes. Well, what about type 2? What about diabetes? So the diagnostic criteria for diabetes includes a fasting plasma glucose greater than or equal to 126, or a 2-hour plasma glucose greater than or equal to 200 following an oral glucose tolerance test, or a hemoglobin A1C of greater than or equal to 6.5%. There's another criteria. You can have somebody who comes in with classic diabetes symptoms, polyuria, polydipsia, blurry vision, and they have a random plasma glucose that's greater than or equal to 200, you've made the diagnosis. What I need to tell you is that the recommendation is you do 2 confirmatory tests, particularly in the asymptomatic group, just to confirm, and that goes for the prediabetes criteria as well. Again, these are ADA guidelines. I want to just talk a little bit about what's going on in the development and progression of diabetes. So what you're seeing on the left side of the graph is this period of impaired glucose tolerance. Then you have this hash mark in the middle to show you the time that diabetes is diagnosed, and then frank diabetes after that. So if you look at insulin resistance, you see this increase in insulin resistance is marked in the prediabetes or impaired glucose tolerance phase. And what's going on with insulin? Well, insulin levels are actually going up, right? So we have this insulin resistance, so the pancreas is chugging out more insulin, trying to maintain normal glycemia. And you see insulin levels go up, but then after you develop diabetes, insulin levels go down. There's actually studies that have suggested that by the time you get a diabetes diagnosis, you've actually lost about 50 to 75% of beta cell function. Again, very significant. And really why we should be focusing on these earlier time before a diagnosis of diabetes is made. I tell my residents, by the time they come to me, they're on insulin. They're on 4 shots of insulin a day. I would have loved to catch them before that. And what happens with hepatic glucose production? Hepatic glucose production is going up after a diagnosis of diabetes. Why? Because we're not getting glucose into the cells, so the brain is perceiving and the liver is perceiving that we're starving, and so the liver starts to release glucose. We see glycogenolysis of the liver. And here's what's going on with fasting plasma glucose in the pink and postprandial glucose. And just to show you that emphasis that I mentioned, that fasting plasma glucose has a little bit of a slower uprise. So if you're going to catch somebody, you may catch them with a post 2-hour or OGTT glucose. And then we know that microvascular complications develop even before diabetes is diagnosed, and certainly true for macrovascular complications, specifically cardiovascular disease. So timely and frequent diagnostic testing matters. You have an informed patient, you need an informed clinician. We need to be able to have appropriate patient-centered education, intervention, and monitoring, with the goal being to delay the onset of type 2 diabetes or delay the progression of type 2 diabetes. So I really have been emphasizing type 2 diabetes, but we know that type 1 and type 2 diabetes are heterogeneous diseases with varying presentation. I have seen type 1 diabetes that presents in adults. We know that type 2 diabetes can present in children and adolescents, and the clinical presentation can provide clues. So a lot of these patients get sent to me. It might be somebody who's 50, 60 years old. They were on metformin for a while, and they got diagnosed with diabetes. They were on metformin, but metformin isn't doing the trick. They come to me and I look at them and I'm like, you really don't look like you have metabolic syndrome. I don't see any signs of insulin resistance. Your BMI is normal. And they actually end up having type 1 or autoimmune diabetes. So keeping in mind that these type 1 and type 2 diabetes are heterogeneous diseases with varying presentation, diagnostic testing can help us out. So in latent autoimmune diabetes of the adult, or similar, so it's similar to type 1. So these are adults who develop autoimmune diabetes. If I can't figure it out, it's not obvious, antibody testing can help me. We most commonly will check glutamic acid or GAD antibody. You can also check islet tyrosine phosphatase or IA2, as well as zinc transporter antibodies. And you can also check a C-peptide and do that, which is actually a little bit cheaper. The caveat to doing C-peptide, lots of patients, when they know they're coming to see the doctor or the endocrinologist, they start to really change what they're doing because they want to be in their best stage for the doctor's visit. You have to be consuming at least 150 grams of carbohydrates for 3 days prior to doing a C-peptide in order for it to be accurate. And then we do genetic testing also for monogenic diabetes. And you may have heard this as maturity onset diabetes of the young. So this is like a type 2 picture in a younger patient population. I'm going to talk about that here in this slide. So adult monogenic diabetes, I've showed you the 4 most common genes. This is most common to North America. There are several other genetic defects that are present in monogenic diabetes that are in other places in the world. I'm only showing you what's most common here. This is what you'll see in about 70% of the MODY patients in the United States. Why is it important to know? It is really important for me to know because it's going to impact how I treat patients. So I'm going to draw your attention to this last one, the GCK. There's a glucose kinase genetic issue. So these are patients who develop diabetes as young adults. They have particularly elevated fasting blood glucose, but it's not progressive. It's elevated and it kind of stays at the same level. And these patients don't develop complications. So they don't need a lot of treatment or aggressive treatment. And that's really important for me to know so that I don't throw them on a bunch of drugs, right? We know that some of these genetic variants do very well with sulfonylureas. They're very sensitive to sulfonylurea therapy, and that is very easy for me to do. And there's the HNF1B. Those patients have type 2 diabetes type picture, do well with sulfonylureas, but they also have some genitourinary abnormalities present. So that's definitely more of a larger genetic syndrome. So really important for me, if I have somebody that I suspect has one of these monogenic form of diabetes, I'm actually doing genetic testing so I know which one they have, and that helps guide my treatment. So what are we doing in patients now? We know they have diabetes. What is their medical evaluation? What should it consist of? So we want them to have a comprehensive medical evaluation initially and at least annually. We want to evaluate for comorbid conditions because we know that type 2 patients, particularly with type 2 diabetes and longstanding type 1 diabetes, will develop comorbidities, cardiovascular disease, hypertension, hyperlipidemia is something else we have to be cognitive about. And they have their functional and cognitive status is impacted over time. And so it's something that we need to be assessing as well. And the other thing that is being brought more and more to our attention and is now part of the American Diabetes Association guidelines is it is our job as clinicians to identify social determinants of health and structural barriers to healthcare access. So my predecessor said, that's not my job. I'm a doctor, I treat. But it is my job because if I can help identify those barriers, then I can provide access to resources that may help overcome those barriers. So this slide is a little hard to read, but this is listing the laboratory evaluation that we do for patients with diabetes. So at the very top, we have hemoglobin A1C. So everybody needs a hemoglobin A1C. The recommendation is to do that every 3 months. If you have somebody who's been really stable for a really long time, you might be able to do 6 months, but generally the recommendation is every 3 months. And then you need to check a yearly lipid profile, liver function tests, spot urinary albumin to creatinine ratio to assess for microalbuminuria or gross albuminuria. And this is really important because it's going to help me determine what treatment I might use for diabetes. Serum creatinine and GFR, thyroid stimulating hormone in people with type 1 diabetes. And there are several others listed here. Why does this matter? It matters for a couple of reasons because we know that patients with diabetes have comorbidities and we need to keep our finger on the pulse of those. And the second thing is this is going to guide my treatment. So if I have somebody who has elevated liver function tests or is being we're now screening for metabolic syndrome associated steatohepatosis. They changed the name again on me, but that is the latest name. I need to know that because that potentially changes the treatment, the pharmacologic agents I might use. So let's talk about pharmacologic management. Another hard to read slide. This is the algorithm for diabetes management. This is from American Association of Clinical Endocrinology. I can also refer you to a very nicely detailed chart on the American Diabetes Association. I love ADA's guidelines because they update them every year and they are available to the public. You just have to go to ADA Standards of Care and you will find all of this information. So we're not treating everybody with type 2 diabetes the same anymore. We are really personalizing treatment, and we're basing that personalization on patient comorbidities. So if I have a patient who has chronic kidney disease, I might opt to use an SGLT2 inhibitor, which has been shown to to preserve kidney function over time in these patients, in these high-risk patients. Also, another a newer development is anybody who's high risk for atherosclerotic cardiovascular disease, which all type 2 diabetics are. The recommendation now is that we should consider a GLP-1 receptor agonist in those individuals. So in patients who have cardiovascular disease or at high risk for cardiovascular disease, those patients we should be considering a GLP-1 receptor agonist and an SGLT2 inhibitor. So again, I'm really personalizing what I'm using to treat my patients based on their comorbidity status. We're also personalizing based on hemoglobin A1C. So you can't see it very well, but on the right side of the slide is this light blue box, and I've sort of paraphrased what it says. So if I have somebody who has an A1C greater than 7.5%, I know I'm going to use one or two agents from the get-go. If I have somebody that's coming in not on anything and their hemoglobin A1C is greater than 9, I'm going to use 2 to 3 agents right off the bat because that's what it's going to take for me to get to my goal A1C of 7. If somebody comes in with an hemoglobin A1C of greater than 10%, because the A1C is so high and there's also a component of glucose toxicity, I'm going to start them right off the bat on insulin. I might do insulin plus a GLP-1 receptor agonist. I might do basal insulin and short-acting insulin, really depending on the patient. And then I'll bring them back and I'll see how is the hemoglobin A1C doing and can I tweak a little bit more. Because of the cardiovascular benefit and the renal benefit, I do tend to use a GLP-1 receptor agonist in many of these patients and SGLT2 inhibitors. Okay, so in conclusion, diagnostic laboratory testing is important for the early accurate diagnosis of prediabetes and diabetes, for the diagnosis and treatment of monogenic form of diabetes, and in guiding lifestyle and pharmacologic treatment. We really need to, I can't say it enough, we really need to do a better job in creating community-based screening programs to be able to find those 23% of the population that have not been diagnosed with diabetes. We need to find our people who have prediabetes because we can really make a difference and impact on their outcomes. And we need to do a better job of monitoring disease progression, complications, and efficacy of treatment. I'm happy to take questions, and I'm going to invite Dr. Kunz up to facilitate questions.
Yeah, let's have a seat. That was fabulous. Thank you so much. It's really all of our pleasure that you were able to join us today.
My pleasure to be here.
So one of the first questions I have harkens back to the beginning of your talk, where you commented on how important it was to capture people in that pre-diabetes stage. So
Yes.
Before they have frank diabetes. What do you see as some of the most likely places where we could actually identify people in that pre-diabetes stage that we're currently missing?
Yeah. I think one of the easiest places to do it is in the emergency room, in urgent cares, in the community-based clinics. We have people seeking medical care when something is wrong. They break their leg, they have a mouth infection. That's when they come in, and that is the time we need to capture them. And we know that there's certain conditions that are associated with diabetes. Certain infections happen more in diabetes and prediabetes. So those should be clinical clues for us. I am, at least in our hospital system, it really took some convincing for us to say, okay, I'm going to get a hemoglobin A1C in somebody I think that is high risk, even though they don't have a diagnosis. And actually, that is the recommendation by some of the Endocrine Society and American Diabetes Association as well.
So, I'm an obstetrician gynecologist by training. And one of the greatest risk factors for type 2 diabetes and prediabetes is gestational diabetes. Also, you mentioned polycystic ovarian syndrome.
Yes.
But what can we be doing as non-endocrinologists to be capturing those patients better who are at high risk?
Great question. So the interesting thing about polycystic ovarian syndrome, there are 2 times, at least for me, that they come to clinic. One time is because they come in and they tell me, I have a lot of facial hair, and I don't like it. They're usually in college. I don't like it. What can I do? And I'm trying to lose weight. So that is a perfect time to capture those individuals. Now, it's kind of hard to tell a 20-year-old or a 21-year-old, like, hey, you're at risk for developing type 2 diabetes. It doesn't always register. But being able to sort of use patient priorities to, number 1, screen, and number 2, get that person into a diabetes prevention type program is really important. The second part of your question is women who have gestational diabetes. You know, women who have gestational diabetes have their baby and they're supposed to come back for a 6-week follow-up. How many times do you think that happens? Right? They're too busy being at home, losing sleep, trying to take care of their baby. And if they're a new mom, forget it. They're not coming in. So we really need some population health programming. We need to bring the testing to them, perhaps, but really having a more robust postpartum evaluation. I will also say I'm from Texas, which did not expand Medicaid, and our Medicaid is getting a little better, but if you are on Medicaid, your Medicaid ends like 4 weeks after your delivery. So after that, you don't have access to care, and that, I think, is a tragedy, and we need to fix.
I'd like to see if we have any questions from the audience. Paul.
Thank you for your presentation. What are some clinical decision support tools that you use in your organization to early identify vulnerable patients? I know that the EHRs have several tools that are available to identify vulnerable patients.
So I think that's a great question. I think there are some EHRs that have clinical decision-making tools in them or are able to do it. It's a matter of, is your health system invested and ready to add on those tools? I still think we're in the infancy of implementation, unfortunately. So our hospital system is more likely to have sort of guidelines, you know, like we call them power plans, where we have some auto orders where we're anybody who gets diagnosed with certain infections will get an A1C, but it's still far from standardized. And I would also argue that the uptake of clinical decision-making tools is still not great nationwide, and that's something we need to work on. And I think that also comes from, you know, a payer standpoint, right? We need payers demanding that we're using clinical support tools.
Hello, good morning. Thank you for a fantastic speech. My question is a 2-part question. You mentioned that 23% of pre-diabetics are essentially unidentified. What percentage of that is in the minority communities? And is there a health disparity that's prevalent? The second part is cost of treatment. Insulin and GLP-1 is extremely expensive, especially with the Ozempic craze and everything. What is your thoughts on that? Are there any initiatives or grants out there currently in the...
Okay. So the first part of your question, so it's 23% of the population that doesn't have diabetes. If you lump in pre-diabetes, it's going to be an even larger percent. So just want to make sure that I said that accurately. And you're right. I think we know that largely these are individuals who are of high-risk ethnicities, lower socioeconomic status. When the FDA commissioner gave his talk about how we're really failing at type 2 diabetes, you know, the point made was, well, we have all this great technology, but the uptake of digital technology is happening in more highly educated individuals and wealthy individuals. We still don't have great payer coverage of some of those technologies. And if you don't have insurance, or if you have a marketplace plan that's bare bones, they don't cover. So we need to really work as a community. You know, we have been working on the cost of insulin and insulin cost supposedly has come down, but it's a very limited, right? It varies depending on where you are in the country, and it's a limited number of insulins. So I think that's something that we still have to work on. Where I am, we have taken the initiative in Travis County, which is the county that I work in, to actually pay for continuous glucose monitoring. So if I, as the endocrinologist, says we have certain criteria, but if I say, yeah, this person needs CGM, I'm able to get it we have a medical assistance program and we're able to get them. We're using a lot of patient assistance programs, unfortunately, for some of the GLP-1s, but our county is also supporting GLP-1 receptor agonists. And I think the problem there is twofold. Number one, you have the Kim Kardashians and everybody else after, the GLP-1 receptor agonist. So there's a shortage. I am having trouble for my patients who have diabetes to get the drug. It can be very difficult. But I think we need to increase availability for sure. Hopefully we start to see the costs come down as more players come into the market. And unfortunately, right now, we know that with GLP-1 receptor agonists, the minute you stop a GLP-1 receptor agonist, the weight comes back. And, we don't know what's going to happen long term. And those are some things we have to think about. Is there a ramp off program? Right now, it doesn't seem like there's going to be. You're welcome.
So with that, unfortunately, we're out of time because I think this is a conversation that we could go on for quite a long period of time continuing with. But I wanted to once again thank you, Dr. Kulkarni-Date, for joining us today at ADLM 2024. And thank you all for joining us as well. Have a good afternoon. And if you have any other questions, please let us know.